Should everyone be on hormone replacement in peri and menopause and postmenopause? Or should we all be embracing doing it the natural way? And where's the in between? And is it all truly debunked that hormone replacement therapy causes cancer? Is there a correlation to it causing cancer? And how much of these therapies should we be using and for how long? And what do we need to know about our own bodies to see if we're a candidate? It's not just asking your doctor and getting one opinion. It's really diving in and understanding. Today, I've got my good friend, triple board certified MD. She is a GYN. She delivered babies for years. She is very familiar with women's health. She's been prescribing and working with hormone replacement for over 30 years. She just spoke at Harvard. She is well-versed on this topic, and she happens to be a really good friend of mine. I've got Dr. Anna Cabeca on today to discuss all these things. Thanks for being here.
Oh my gosh, always fun to talk with you. And also, again, really dig deep on these topics that aren't talked about enough in a healthy way.
So I've had Dr. Anna on many times before, and I'm going to repeat a little of the information, but there's really another area I want to dive into today that I was discussing with Anna. So Anna, what I see lately is this, it's kind of like this black and white either or. There's the team HRT for everyone, and there's no outside of that. And if you're not doing it, you're missing the boat and you're missing out. And everything that we've been told about hormone therapy being dangerous is debunked and wrong. There's that camp. Then there's a camp of, I'm going to just do it natural and I don't need to. And my doctor said no. And maybe I'm estrogen positive, breast cancer, whatever it is, and I'm an extreme no. What I don't see talked about enough is this middle ground of maybe it's not for everyone truly, or maybe if it is for you, it's not at the levels you think you should be doing. There's this middle ground, and there's a whole other area of our own nervous system. So it's like our DNA and how that's expressed, how we've been living toxic life or detoxing correctly, how that's working in our bodies, but then also our nervous system and what that has to do with it. So those are the areas I really want to dive into with you today, if you're down with it.
I am. Again, they're not talked about enough. There's a healthy way and unhealthy way, and each of us is different and unique, and understanding that, doing what's right for us, and feeling empowered and healthy in our body is key.
So let's start with, you've been doing hormone replacement for a long time. Before it was trendy, you saw it come and then go and then come again. What are your overarching thoughts about it? Like, give us a general, what's your general thought process around hormone replacement therapy?
Yeah, there's a right way and wrong way to do hormones. And each individual, so for example, just thinking of my clinic this last week, I had 2 women coming in their 50s, mid 50s, same issues, the menopausal symptoms, mood swings, irritability, brain fog, hot flashes, weight gain without doing anything different. But both of them left with 2 different treatment plans, right? So it's really important to customize the treatment and intervention based on the individuality of the patient. What's her detox pathways? What's her toxic exposure? What's her stress level? What's her diet and nutrition plan look like? How's her lifestyle and relationships? What else is going on? Because I don't ever look at one aspect, because if you think of this like a bicycle wheel, and all the spokes on the wheel are different things. There could be medical issues, psychological issues, environmental issues, relational, and the list, toxins, environmental toxins, etc., different things, nutrition, diet, supplements, all of those are different spokes on the wheel. So you want to look at what's going on with their health, with their nervous system, with their cardiovascular system, and with their endocrine system as well. These are different perspectives to take into account and customize. And women also, right time, right place therapy is so, and intervention is so important. But like I like to say, menopause is natural and mandatory, and suffering is optional. And it takes more than hormones to fix our hormones.
When someone says that, I'm going to start with some bold questions here, because these are just what I see on social media and what comes up. Anytime I post about HRT or anything that has to do with it, I'll have someone in the comments say, my friend or I or my mom or my sister was totally healthy, did hormone replacement, and got cancer. And I don't want to say that that's not true, because I'm sure they did get cancer. What is your feelings about that? Is it the hormones that cause it? What's your thought there?
Yeah, this is a really important thing to understand is when we have a diagnosis of cancer, what are the underlying causes of that cancer? What's related to toxic burden? Toxins, molds, like all the hormone disruptors, and the second big part of inflammation in our body contributes to cancer. What's causing that? Inflammation. What's the underlying reason for that inflammation? Blood sugar control, hyperglycemia or diabetes, insulin resistance increases your risk of cancer. Stress increases your risk of cancer. All of these issues have to be addressed. And Natalie, it's such an important question because typically we say that cancers are growing 10 to 15 years before diagnosis. Well, what have we been doing, prior to those 10 to 15 years to increase our susceptibility to that cancer? Has it been long-term birth control pills? What's in our environment? All of these aspects, and stress as a trigger is huge. How is our body detoxifying estrogen and these hormones? Early on in my practice, I had a beautiful 47-year-old woman who came in to see me. Mm-hmm. And she'd had 7 years prior a diagnosis. So in her early 40s, she had a diagnosis of stage 1 breast cancer. And when she came to see me 7 years later, she had all the menopausal symptoms: brain fog, mood swings, vaginal dryness, tore when she tried to have sex with her husband. And, she was like, I have to do something. I can't live this way. So the first thing we have to ask is, what caused your breast cancer to begin with? What did your doctor say? I asked her. Mm-hmm. They never addressed any kind of cause. And so went through her history, and, she worked in a pulp mill, which had formaldehyde, and she lived on a farm which was heavily sprayed with glyphosate. And, she had diarrhea, irritable bowel syndrome for a year. Her vitamin D level, so blonde hair, very pale skin, her vitamin D levels after her breast cancer diagnosis, and this was 7 years later, no one ever checked them, the vitamin D level was 17. So well below the 50 that we think as, the beginning of optimal. And so there were these issues that we had to, and then I did a genetic panel on her as well to look at markers for methylation, for sulfation, for glutathione. I wanted to look at these markers because I want to do something healthy for her and I want to empower her body. But if I don't address the underlying reason she got the cancer to begin with, I in my years of practice, haven't seen using bioidentical hormones cause cancer. There's always an underlying cause, but we have to address those detox when we're prescribing and using hormones. We have to make sure our body's detoxifying them in a healthy way. The gut has to be healthy. The liver has to be healthy. Glucose metabolism has to be healthy. I mean, all of those aspects are really important. So once we got through that initial phase of detox and addressing these issues, optimizing vitamin D, we used hormonal therapy. So that was early on. So she's now 70.
Oh, wow.
So, 65.
So I have a hypothesis, and maybe I'm onto something here. Maybe you're like, many people have said this, or maybe you're like, no, Natalie, you're completely off the mark, but I'm going to share it because this is just what's coming to my brain. So we're all genetically different. And when you do genetic testing, which I'm a fan of, and so is Dr. Anna, and you have, you show that you don't have amazing detox pathways for estradiol, for example. What happens is before menopause, you have a period every month. You menstruate. So when your body's producing hormones, you have a period, it cleans out all the gunk. So used estrogen, everything comes back out. So then your body's producing it, it's cleaning it out. So then what happens is perimenopause, that slows down. Then now menopause, you're not cycling anymore and you are adding back in hormones like I am, estradiol. Your body no longer has menstruation every month. So what happens with those used estrogens if your body doesn't have good detox pathways? So my theory is, again, based on nothing but Natalie's opinion here, and I'm not a doctor, so that's why I'm asking you. In my brain,
you're
I'm thinking,
a great detective and
Yeah, because I'm a detective. If you're taking hormones and you're not menstruating and you don't have great detox pathways, unless you really pay attention to how will I get my body to eliminate this, things like broccoli sprouts or calcium deglutarate, or even maybe DIM in some cases, then that could build up and create a cancer or a problem. Am I like completely whack here, or does this make sense?
Well, no, it absolutely makes sense. You have to have those detox pathways open. And this is what we know from the science. But first, I want to go back to that monthly menstruation, which I didn't think about this until you said that. Monthly menstruation, right? We're, cleaning out the uterus, bleeding, but it also gives us, we have to we're going to rebuild that blood supply over that month. So we're increasing our own stem cell production. So that's got to help us, right?
So now Harvard needs me to speak, clearly. I put this, just kidding. Well, but it's making sense to me that if you're not bleeding every month, where is that going? So, and if you're going into hormone replacement not metabolically optimized, or you've got other things going on, maybe you were exposed to mold, maybe you've got excess weight, whatever it is, you list the thing, high cortisol, like you mentioned. Now we're adding hormone replacement, and your body doesn't have a cycle. We have to think about where is that getting stored, and it's going to get stored in fatty areas, which like could be your breasts, and that could be breast cancer. So I feel like saying that hormones don't link to cancer is not true. Like it can, depending on the way your body is, maybe.
Well, according to the research, when we look at that, so if we think of the science and go back to the 2002 Women's Health Initiative study, it was looking at oral Premarin, which is conjugated equine estrogen. So that's pregnant mare's urine, so Premarin. Okay. And there's over 30 estrogen, and estrone prominent. So it's more of a toxic estrogen to our cells. So we had that study, and even in the oral progesterone only arm, that did not have a significant increased risk of breast cancer. So even that in the 20-year follow-up study that was published last year or year before, it showed that yes, that estrogen-only arm did not have an increased risk of breast cancer. What was significant with the increase of breast cancer was the progestins, the synthetic progestins. And that was Provera, medroxyprogesterone, which is a pregnane derivative of a progesterone. So it's a more toxic form. And in 2008, Dr. Fournier published his EPIC trial looking at estrogen and progesterone, really looking at progesterone in perimenopausal, menopausal women, and looked at different forms of progesterone. Oral micronized progesterone, which is bioidentical, and then the Provera, so pregnane and norpregnane, like norethindrone, different types of progestins, which are not progesterone, but the literature has been really confused about that. And what they saw was an odds ratio increase with the pregnane derivative, so like Provera, of 3 times the risk. So we saw 3 times risk, but with progesterone, we saw no increased risk, a 1-to-1 ratio. So we can look at that and say, all right, even in the non-ideal detox clean population, but these are Europeans, so they don't have the levels of toxic burden that we have here. So if you look at that and you can say, okay, well, the oral progestin should be just a straight no. Well, they're in birth control pills. Right. Women have been on them for decades at this point, and that is toxic too. I mean, we know it's a toxin. It also depletes different nutrients, B vitamins, magnesium. It burdens our detoxification pathways. But then we also had last year published the 10 million woman study, which looked at a Medicare patient. So that's Medicare, typically age 62 or 65 and above, who are on different forms of hormones. And then looking at these different forms of hormones found that the bioidentical hormones did not increase morbidity and mortality.
And this was everything. They looked at estradiol, like all the different ones.
All the different ones.
Interesting.
Yeah. And so we can look at that and say, okay, but is estrogen, like if we're using hormones with high toxic burden, inflammation, diabetes, cardiovascular disease, autoimmune issues, and we're not addressing any of these underlying issues, could we potentiate something? I think that leaves us to keep that as an open question.
Then I have another hypothesis based on nothing that I'm going to share because I go down rabbit holes here. I believe personally for me, and where I feel safest is doing levels that are enough to get you out of symptoms and be somewhat preventative, but not trying to replace to levels of 10 years ago, 20 years ago, at these high levels. And it concerns me when I see some protocols out there, like the very known Wiley protocol, where it gives you very, very, very high levels of things like estrogen at certain times of the month, trying to mimic a cycle. So where, just to give you all numbers, if you've done blood testing and hormone replacement, post-menopause, you could range all different areas. My personal estradiol was 15. It was super crazy low. And by me doing a patch, topical patch, I get it to about 60 or 70, which is conservative. It's definitely not on the high. It's just enough to get my hot flashes out of. And there's some studies that it'll help protect brain and bone and things like that.
And bring your FSH down.
Which my FSH is not perfect. It's still kind of up there, but I'm going to talk about FSH in a minute. But I have friends that will do estradiol cream, for example, or injections or oral to get it up to 500, 600, these really high levels. And then they'll do that for half the month and bring it back down. And to me, that feels risky because we're not truly cycling. And that's very high levels trying to biohack something from years ago. So I wanted to get your opinion on that. And if you think that's dangerous to play with that.
Well, I definitely do. I've seen high doses of estrogen and estrogen pellets users and high doses of testosterone early in my practice in the 90s and early 2000. And, when you have a client with those issues, with those high levels, that's high toxic burden. You think about our entire nervous system. It has to function properly. It's suppressing, those high levels are going to suppress the HPA axis, just like what birth control pills do. Your ovaries shrink. We know that high testosterone replacement in men at high doses shrinks their testicles, right? They get, they shrink, and that's, can do things to prevent that shrinkage. But that's a consequence, because when you stop, for whatever reason, you have to stop. Finances change, you move, your doctor moves, or something else happens in your life where you're like, I can't get these prescriptions anymore. Now you have your what happens clinically, and scientific research has shown high incidence of depression and suicide. So what have we done to that HPA axis? I always want to enhance the body's natural processes versus suppress them. So I think that's really important, and when we're on hormones, again, that hormone detox it just needs to be part of it, part of the plan, part of the program. And I never want to do anything at such high levels that I'm suppressing your body's own natural function. There's no research long-term on these high levels.
Does the ideal level vary for every one of your patients, or do you like to see a specific number? And I'm talking post-menopause right now. Do you like to see a certain number, range that you like?
Yeah, for estradiol, it really depends. But 50 to 80, 60 to 80 range.
So what I said I figured because Anna's my doctor. So that makes sense. So 50 to 80 is that's what you like to see because it gets them out of symptoms and it feels good. So when you see somebody with much higher levels, is that when you start questioning detox to make sure that's all happening?
Question detox, question how much they're using and how they're taking it. When did they get their blood work after they took, say if they're on an oral estrogen, they took their oral estrogen and then did a blood work that morning. Well, that would explain why it's high. So you still always have to, treat the patient, not the labs, but you have to figure out when we're testing. And that's been a question we had. Okay, when did you put a patch on?
Yes.
How many days after? Before you change to the next patch, let's look at, try to do that reproducibly and see what's going on.
Yes.
So I think I'd also question, I always look at, if someone I'm managing on hormones, I want to do it safely. So I'm going to look at the estrogen detox pathways and the estrogen metabolites, the 2-methoxy and hydroxy estrogen and 4 and 16 hydroxy estrogen pathways, because that gives me an indicator how their epigenetics are working together.
By the way, this is really an important thing you just said. Now I have 2 doctors that I work with personally. They both are friends. I'm not going to mention the other one's name right now, but they differ on this. However, so my one doctor, she's like, nope, we just do blood for hormones. That's all we need. And I like Anna's approach. So I do my hormones through Anna because she doesn't just look at blood serum. She looks at urine because that's the only way to know how it's detoxing. So if we just go off of blood serum levels at any given time, first of all, they can vary, but we have no idea how that is going, how that's changing in your body over the day. Did I say that right?
Absolutely. Yeah. And there's different ways to look at hormone. Like our body fluid tells us something. I mean, for heaven's sakes, it was a $50 billion industry by giving women pregnant mares urine, right? It became, because there's so many hormones in it. So why won't we look at what that is? What is our body doing right? What is it maybe needs support around? That's, I think, a key part. Our saliva tells us something different. I don't use salivary hormone testing if someone's already on hormones, but on a rare occasion, I will. I want to make sure the gut's healthy, and looking at their blood markers, also gives us another picture, because you can have certain levels in the blood, but very different presentation in the urine, and so that helps me understand what your body's doing with these hormones. Are they using it? Are your receptors receiving this hormones? Do we need to do more to clean up the hormone receptors so you use this hormone versus just giving you more hormones, more hormones.
Before I ask you about progesterone and testosterone, which I'm going to in a minute, I want to ask you about estradiol versus like bi-S, and also the forms. Like, I'm, again, confusing for people. I've heard that the oral or the injection goes through your liver, where topical, like a patch or cream, is safer. And then I've also heard from people that bi-S, including me, bi-S did not work at all. Can you help us understand that? Like, what's the difference between all of this?
Yeah. So different modes of delivery. And then, of course, there's estrogen pellets as well. So oral estrogens do get metabolized by the liver. First pass metabolism is through the liver. And that's where we really need to make sure our detox pathways are working optimally. But it also increases inflammatory markers. And oral estrogen has been shown to increase your risk of strokes. That was shown in the Women's Health Initiative study. Wow. That was shown in the HERS trial in the 90s. So we know oral estrogen does that. So we never want to use, oral estrogen in someone at risk or without checking their cardiometabolic status. So what was the other part of the question?
About bi-S versus estradiol. Like, what is bi-S? And like,
bi-S is E2, E3. You may have heard like tri-est is E1, E2, E3. Bi-est is E2 and E3.
What does that mean?
So estradiol and estriol, these are other hormones that our body produce with different types of estrogens. And so estriol is the weakest form. It's really predominant in pregnancy. It has some immune supportive effects. Like estriol has been studied in people with multiple sclerosis to reduce plaque formation and improve cognition. So estriol at high doses, like at 8 milligrams, there were studies back in the early 2000s that looked at that. So it has a beneficial effect. Now, how much does that help with hot flashes? So, very little. It can help support skin. It can help with vaginal atrophy.
That's what we use for face or for vaginal, correct?
Yeah.
Estriol.
And estradiol is is a potent estradiol, and you can get that in patches, vaginal rings, sprays, gel, compounded the combination with estradiol and estriol. Some people have a hard time absorbing the creams, the topical creams. Don't absorb them as well. And the patch has a good delivery system. It's straight estradiol, but it has a good delivery system, and it gets well absorbed. We can see those numbers in the blood.
So if we're using estradiol patches, which a lot of people are, including me, should we be adding estriol for those other benefits? It seems relatively harmless.
Well, we spend a lot of money on skincare. I know we both do, right? Like it can be expensive. So we can see how that works for us. But then the estriol for hormonal support, I don't know that I think it's something to consider for topical benefits and for additional immune support.
Okay.
There are there's benefits to use it. I personally use a combination of E2, E3. So I do well with it.
So do you do a patch and then a cream? What do you do? A troche. So does that considered oral then?
It's considered submucosal or buccal, but you are swallowing a little. But I
So
watch
it's going through your liver still.
it's a portion of it's going through the liver, but you're also getting lymphatic absorption, salivary
Got
gland
it.
absorption.
Okay, so by the way, on the patch, Dr. Anna and I figured this out kind of by accident, but because I'm a patient of hers, I'm on the patch. I've been on the patch for probably a year, and they were working great until a few months ago, and I was like, why all of a sudden are my patches not working? Like I've had to replace them a lot more. I've doubled up on them. Like I get hot flashes. And finally figured out that I was on the name brand. And then when I switched to CVS, they switched it to a generic. So I'm not knocking the generic, but what I learned after we figured this out is that the name brand there's a variant. So it can be a lot less. So if you are like have been thinking your patch doesn't work, definitely try switching brands. So, and we also learned this, like mine goes through CVS. We learned that you have to have your doctor, your physician literally write, do not replace and do it with the name brand.
Yeah, do not substitute or substitution not permitted.
Yeah. And as like I'm recording this, I still have 2 of the other kind on because it's like literally it takes 2 every few days in order to get that. So can't wait to go back.
Well, that was good detective work to figure that out because we were blaming it on surgery.
Everything. No, it was literally this. Who would have thought? Didn't even occur to me, and now that makes sense. So okay, so if you are on estradiol, or estrogen replacement, according to Dr. Anna, and again, you want to talk with your doctor, but the recommendation sounds like you ideally want to work with your body considering, but between 50 and 80 postmenopausal is a great number. It's a safe number. There studies support
for estradiol serum levels.
Yeah. Serum levels. But it's important to also be testing the urine. So that could be a Dutch test. There's other methods, but the urine test, which tests how your body's detoxing it. And then bias kind of up in the air, whether it definitely was not effective for me. So, but again, up in the air for you, but the estradiol is what is actually going to help with the hot flashes and the mood and all of those things. When it comes to testosterone, I've got some questions here now. My first question, before I even talk about testosterone in general, what the frick does it mean when they say it's aromatizing to estrogen? We hear, what does that mean?
So the way, pathways that will go, testosterone will either convert, so it just means conversion, convert to dihydrotestosterone, a potent form, and that's a different enzyme, 5-alpha reductase pathway, versus testosterone will aromatize to estrogen in both men and women. So if you have ever seen guys with boobs, right, male boobs, they're making too much estrogen. They're converting testosterone to estrogen.
So is that a good thing for women post-menopause? We want that?
Well, it depends on your genetics, right? It depends on your genetics and whether you do it, and you'll naturally do it. Testosterone converts to estrogen. That's how we make our estrogen. But in times of stress, we're going to activate that 5-alpha reductase, and then we'll get to the dihydrotestosterone and get male pattern baldness, acne, weird hair growth in weird places. I don't know. But so it's important to know what your body's doing, and that you can't figure that out in a blood test. You really need to look at that with the urinary pathways.
Okay. If it does aromatize to estrogen,
which it is,
is that usable estrogen? Is that estrogen?
Yes, that's how it,
so it can actually help your estrogen levels if it's doing that.
So we basically, circulating in our blood, we have a lot more testosterone than estrogen because testosterone converts to estrogen. It also converts to DHT, but that's how we get we get estrogen through this testosterone conversion.
Okay. So, now testosterone in general, let's talk about that for a minute. I feel like mine's not working currently, but I'm not talking about me. I want to talk about everyone listening. We talked about numbers for estradiol. What do you feel is ideal or safe for women, aside from they're all being warned about the hair and the male pattern baldness, but a lot of women, including me, wanted it for sex drive. We want it for that focus and energy, and we want it to help building muscle, retaining muscle. Like, what's the right number? And is there any, besides the male pattern baldness, which is obviously a big thing, and the acne and the hair loss, clearly that's from a lot. Is there like an ideal number you like to see people at? Do you recommend all women explore this, or do not all women need to do this?
So, yes. I mean, testosterone is an important hormone as looking at thyroid hormone, even more important than looking at estrogen because, again, testosterone converts to estrogen. So we want to look at this, and it is important in a holistic, for a holistic approach, and not just, again, if the testosterone's low, we can assume if we're 60 that it's going to be low. But we still have to ask why, because we have people in their 20s, 30s, 40s that have low testosterone. We have to ask why. What's going on? Is it, the toxins, hormone disruptors, blue light, smartphones, EMFs? I mean, there are scientific studies showing these things absolutely affect your testosterone levels and fertility and virility. And so testosterone's, again, because we have more testosterone than estrogen. I don't know. I don't know how estrogen got all this press, honestly. It is important, but testosterone's like
it's a big one. Well, how more important. I guess it's confusing. Okay, so like I'm gonna just pull up numbers. Like a lot of people, like me included, we have total testosterone goes higher, but our free testosterone is too low still.
Because
so
your
what
sex
does that
hormone
all mean?
binding. Yeah, because when you're really insulin sensitive, your sex hormone binding globulin is high. And again, this is why I always check sex hormone binding globulin.
Okay.
So SHBG for short, sex hormone binding globulin. So you can have a great amount, like we say, conservatively 40 to 80 on testosterone.
On total testosterone?
On
or
total
on free?
testosterone levels. If we're using pellets, it could be in the hundreds to 200s.
Okay.
I don't like to see it above 300. There are people that love it there.
Yep.
But typically for
I think
testosterone,
you'd be humping everything at 300.
And
I'm just saying, that would be a crazy sex drive.
Yeah. Well, and it really depends on how, like when I say that level, like say if you're not on hormones, we want to see it there optimally. If you're on creams, we're not going to see it as much in the blood. We will see it more so in the urine. If you're on vaginal, we'll see it in the blood and urine. If you're on pellets or injections or troches, we'll see it in the blood and urine. So, but cream, sometimes like you can be on a cream, you're like, I'm not seeing a bump, but I feel better, I'm doing better. And that's where it gets dangerous. The doctors will keep going higher and higher and higher, or you'll be taking more and more testosterone. Then all of a sudden it stops working. Yeah. All the things that you felt like, oh, I no longer have the libido, I no longer have the drive. My numbers are good, but I'm not feeling it. I think that has to do with the HPA suppression. We really need more studies in this area. But, that's one of the consequences. And so when your sex hormone binding globulin is high, your free testosterone percentage is going to, you're still not, it's bound. It's not bioavailable.
So you're basically taking it kind of for nothing. It's not really doing anything.
I think it's still doing something, but you're not getting as much benefit. And we need to, and that's when we'll have to work on increasing, naturally trying to get your sex hormone binding globulin a little bit lower, or you may need more testosterone in these situations. But a free percentage of 4 to 6% is good.
Okay.
You don't have to go to 10%.
This is another Natalieism, being a detective here. So again, Natalie with a mic, not doctor's advice, but Anna knows probably what I'm going to say here. So I was on injectable testosterone, very low dose. I think it was like 5 milligrams, the right amount. Am I saying that right?
Yeah.
I don't even know. It was a very low dose of injectable. And what was happening when I first started doing it, I'm like, I love this stuff. It was amazing. And then what I realized is I was refrigerating it. You're not supposed to. So usually it comes with, it's in MCT oil or something else. So whatever I was doing, I think my theory is the oil was not coming into my syringe, and I was probably getting very high amounts straight testosterone, which explains why. I mean, I'm sure my husband was very happy. My sex drive was like, what is going on? So when I then
your
learned
receptors were primed because you had been low, and then all of a sudden we give it to you and you're like, woo. Yeah.
Yes. So then when I figured out you're not supposed to refrigerate it and you're supposed to do the right amount, it's not working quite the same. So I'm still figuring that out too. But so note to y'all, you can't refrigerate it. Like I know we refrigerate other peptides like BPC 157, whatever. You cannot refrigerate your testosterone. Some people do injections like once a week. Some say twice a week. Do you have any preference on that or on how they're doing that?
It really
and what are your thoughts on pellets in general?
Yeah, it depends. Well, for injectables, I do like testosterone injectable, but it's a pain in the ass, right? Like
I don't think it's a pain. It's other than it gives you a big fat needle because it wants to go in your muscle.
Yeah. Well, I mean, it just one thing you just have to remember it, but once a week is nice.
Okay.
So with testosterone injection, it really depends on the individual, because when you're getting that, say 5 milligram, 10 milligram dose, you have a peak in 3 days and then it's down to your next dose. And some people, for some clients, it is better. And for men, we do usually twice a week injections. But for women, typically 1 time a week is good, but it depends on your metabolism. If you're a rapid metabolizer, twice a week gives you more stability. And again, a little bit goes a long way.
That's what I do.
With testosterone pellets, I used and trained physicians in testosterone pellets, and I dug deep into the research again in the early 2000s. And one of the things that I noticed, and I used pellet. Like, this is the perfect person. When I had a pellet put in me, I was the perfect person to do, because I was crazy. I was single mom, kids are in schools, 3 different schools, running a business, running a med spa. I couldn't remember to take a vitamin, let alone anything else. Pellets
It was perfect.
I'm good. 4 to 6 months.
Yeah.
That's good. And then I studied the work of and had known and lectured with Dr. Rebecca Glazer out of Michigan, who was a breast cancer surgeon who uses pellets sometimes with an astrozole. Did I say that correctly?
You said astronaut first. That was kind of funny.
Astronaut.
That's going to be the clip I pulled
With
from
something.
this episode.
And, so with aromatase inhibitor in patients with breast cancer, but would use these higher doses and found testosterone to be very safe in these situations.
Is aromatase inhibitor mean it forces it not to convert to estrogen?
Right. In patients with breast cancer, it's...
Got it.
Yeah. So she was using it as a treatment, androgen therapy for treatment. So we know like testosterone therapy is safe. You got to know where it's going to make sure those issues. But again, the functional medicine approach is to look at all the aspects, the gut, the liver, the kidneys, the bowel movements. You have to, and whatever you're doing, if you're on hormones, you have to be having daily bowel movements at least once a day, ideally twice a day.
Oh yeah.
You've got to keep those that's part of the elimination. That's phase 3
no
detox.
Poop, no HRT.
That's right.
Be the sign.
That's
no
right.
poop, no
That's
HRT.
We'll
okay, my other doctor,
title.
who we're friends with, who I won't mention her name right now, but I'll have detectives that figure it out, who I absolutely love. She's brilliant when it comes to stem cells and everything else. I asked her, I'm like, should I switch to the cream instead of the injection? I feel like I don't feel it, because she prescribes the testosterone, and she said, if you want to grow hair on your arms. I was like, wait, what? is that a thing? Do we grow hair where we put the cream?
This is funny, because one of the lectures that I heard recently was talking about testosterone, and she says, she rubs it on her inner leg. So what if I get hair there? No big deal. But you could see a patch of hair on her leg.
Oh, that's funny.
I was like, for my clients, I'm like, vulvar vaginal area. So you make an increase in hair in the vulvar tissue, but it's perfectly safe for the vulva and the clitoris. You get great, there's no hair growth on the clitoris, right? But you get that it's a pleasure zone. So you get that increase in sensitivity and pleasure without the consequence of hair growth. So vulvar vaginal areas where I recommend using testosterone. You can rotate it on other areas, because it's also good for the skin.
Yeah.
Will reduce fine lines and wrinkles. But if you're using it on your chin or on your arm,
wouldn't be doing that. I'd put it on my
it's a waste. It's a waste to put it there. Put it on put it on your clitoris, Natalie.
Okay. All right. I'm gonna have to get some cream. Okay, talk to me about progesterone, and do we have to cycle it? And I know what she's gonna tell me, but just for the record, I was not a good patient here, and I refused to cycle it because I can't sleep if I cycle it. So that's not what Anna's gonna tell us. But talk to us about progesterone and why, and should we all be taking it if we're doing estrogen replacement, and do we have to be doing estrogen with it, and how important is cycling?
So let me tell you a story. So one of the things that I learned about progesterone, because as I trained at Emory University in Atlanta, and we were taught that if a woman does not have a uterus, she doesn't need progesterone. Because the research on Premarin when women were just given Premarin, take that purple pill, advertising everywhere. Do you want a happy wife? Make sure she takes her Premarin. I mean, the advertisements were truly obnoxious. Yeah. And so every woman was getting Premarin. They felt better. It's great. It was a good estrogen, combination of estrogens, until they started getting endometrial cancer. And then they're like, okay, Wyeth Ayers actually did research in the drug metabolism department at Wyeth Ayers before medical school. So Wyeth Ayers, the makers of Premarin at the time, they've been bought out, but they said, okay, well, let's come up with another drug. So they came up with Provera, the progestin. Couldn't patent progesterone, and when we did get Prometrium, which is bioidentical progesterone, they didn't patent the progesterone, they patented the delivery system. So that's why we have this form of bioidentical progesterone we could use. But anyway, Wyeth Ayers comes out with Provera, And then then what we saw was later an increased risk of breast cancer and heart disease. But that's why they said, because of the negative cardiovascular effects of Provera, if you have a uterus, first of all, if you don't have a uterus, you don't need progestins. Okay. That was what clinics, that's what we were taught. That was in our textbooks. And that's still maybe something you hear from a physician. But I had dug into progesterone research early on. And when I started using it for patients who'd had a hysterectomy, and they'd come back and say, Dr. Anna, I feel like so much better. The world went from shades of gray to multicolor again. It is again, I feel like my old self. I feel like the cloud has lifted. I heard that over and over again. So I started studying the neurochemistry of both progesterone and pregnenolone, these two mother hormones derived from cholesterol. And it is a neuroprotective hormone. It metabolized into allopregnanolone and derivatives, and that increases GABA. Every hormone, progesterone, testosterone, estrogen, have a sister neurotransmitter. For progesterone, it's GABA, testosterone, dopamine, estrogen, serotonin. So you can't separate the brain and the body in this, right? So that GABA helps you get a good night's sleep and is restorative. It's a neuroprotective. It helps with mood, helps with bone health. So why would we limit that benefits to women with only a uterus? And why would we not offer it to women in general for preventive maintenance or preventive health?
So why do I have to stop doing it and cycle it?
So
why
there's
do you insist on that?
Because it is one of the mother hormones, right? Because we go from pregnenolone and progesterone to DHEA, testosterone, and estrogen. This is in a cascade. So with progesterone and pregnenolone, so these are higher up hormones, and they're the most abundant from our sex hormones. They're the most abundant hormones in our body. They have neurologic, nervous system, cardiovascular, orthopedic benefits, right? Have all these benefits, and skin and hair. So figure there's stuff in there. And so we have these, we have these mother hormones, and it can, if you're doing often we 200 milligrams, 400 milligrams oral versus transdermal. And so when you're on these doses, you can potentially suppress, like birth control pills, the progestin suppress the HPA. You could have, so theoretically, you can become more resistant to the benefits of it. Again, filling the, tank to overflowing versus allowing receptor sites to have a break and continually be responsive to these hormones. So there are some people who say, nope, absolutely, do them every day, no problem, should not make a difference. Yet I think there's more research that needs to be done regarding that.
So do you have more stubborn patients? Do you have more stubborn patients like me that refuse to not take it every night?
I absolutely do. Okay. I absolutely do, because you can't do, but eventually you'll be able to.
Yeah.
Right now, no, but eventually you'll be able to. In general, when I did my 92-hour dark retreat in the dark, I detoxed from everything. No hormones, no whatever, no thyroid, no hormones. And, I'm just cleaning out everything. What can my body make for me?
Yeah.
And so it's not a bad idea to do periodically. But again, there are seasons for a reason. If we mimic Mother Nature, there's always a winner. Yet in science, we need more research on this. We need more support. I have found that when my clients do take eventually in the perimenopause, early menopause, may not be able to, because that night's sleep is so important. If you're not able to get a good night's sleep, you're definitely not gonna like me or like taking a break in that progesterone. So it's okay for now, but it's a good, I think we need to see what happens. I know that in clients that long-term have been on hormones, it's just like a 3-day detox at the end of each month.
Talk to me. And what we skipped right there, and I'm going to get into how doctors are medicating people through, because I want to talk about that, and I still want to talk about nervous system. But what I skipped was, what is supplementation wise? I mentioned 3 that I like for detoxing estrogen. Does Mighty Maca include all that? To help us understand, personally, I know broccoli sprouts, like just eating broccoli sprouts or even getting freeze dried or powdered, which is what I actually use because I can just take a spoonful, is one of the safest, easiest ways I know to help detox estrogen. But I don't understand why. Can you help with why does broccoli sprouts do that? And talk to us about DIM and calcium D-glutarate and also mighty maca.
So like the broccoli sprouts are rich in sulforaphanes. Sulforaphanes help with detoxification. So we think of the pathways to detox, phase 1 and phase 2. Phase 1 is the hydroxylation pathway.
Yep.
Phase 2 is methylation, glucuronidation, and sulfation. So when we're looking at, depending on what your genetics are, right? If you have impaired genes, like say, for example, a GSTM, one heterozygous or homozygous gene, and you're not making glutathione, you're not detoxing, you can make more 4-hydroxyestrone, which we do associate with higher risks of immune issues, breast cancer, etc. So we want broccoli seed extract or broccoli seed. These sulforaphanes help support that pathway.
Does it help aside from estrogen detox? Does it help with detoxing other things by taking those? Okay, so it's just a good thing to take.
Helps with, yeah. It's a good thing to take. It's a good thing to include, like broccoli sprouts in your diet, definitely.
Yes. Which I do. I do broccoli sprouts every single day. It's like harmless. Now, calcium D-glutarate and DIM, if I did that every day, and a lot of people, you would basically counter your estrogen. So you're actually going to start getting hot flashes again. But what's the proper way to use those? And do you even like those two things?
Well, yeah, definitely. Again, like this is where looking at your hormones closely and also your symptomatology. Do you have estrogen dominance? And this is where DIM can be very beneficial and calcium D-glucarate in clients with estrogen dominant symptoms. And you can take it for perimenopause, and PMS symptoms. You can just take it 2 weeks a month, for instance. And it is helping the methylation pathways. And then calcium D-glucarate's helping the glucuronidation pathways. So the three cover all three, but what exactly, and that's why many hormone detox supplements have all three in them, because we're covering it all.
What I personally do, I do broccoli sprouts every day. Even when I travel, I do the powder. I do calcium D-glutarate once a week, and I do DIM once a week. And then in my head, that's how I'm detoxing with those.
And then we're going to retest. But the key thing was you noticed that doing it daily, you had hot flashes again.
Too much.
We haven't changed your hormones.
Nope.
What else are you doing? What's going on here? And that's where you have to be your own detective work. And
does mighty maca have any of that in there?
Mighty maca has milk thistle. It has a lot of crucifers in here. Maca itself is a cruciferous vegetable.
So that's going to still help with that first part of the detox. And then I would imagine, what does
milk thistle? And it has
milk thistle helps with your liver, correct? So it's going to help with your liver detox.
Yes.
Milk
thistle helps with liver. There's vitamin C in here, the acerola cherry, and it does have the brassica. So it has the broccoli stem and flore, essentially it's flower. It's, the leafy part of the broccoli too. So it has both.
So you're going to get detox from taking mighty maca.
It does support detox. We definitely see improvement in liver enzymes. We see an improvement in inflammatory markers. So we do see an improvement with that. But for someone with estrogen dominant symptoms that persist, that's why for me it's foundational. Mighty maca is part of my foundation. How do you do with it? Well, I know I'm helping your adrenals. I'm helping with detox pathways. I'm helping with glucose stabilization. But then what else do we need on top of that? Yeah.
And by the way, could you speak into this real quick because you just brought it up, estrogen dominance. You can be low estrogen and estrogen dominant.
Absolutely. I really look at estrogen dominance as progesterone insufficiency. And the other reason for estrogen dominance is the hormone disruptors and toxic, estrogen mimickers that are in our skincare products, like parabens, for instance. That's a hormone disruptor. And plastics.
It is so important to learn ourselves all this information, because otherwise I'll tell you, when my estradiol was a 20 on my labs, a 20, and I was having massive hot flashes, my previous doctor before Dr. Anna told me I was estrogen dominant and put me on DIM. Do you know what a disaster that was? Talk about, I had hot flashes 5 an hour. So because in her mind, estrogen, not, I'm like, but I have no estrogen. So that's why we have to learn these things.
You needed progesterone first. And typically my order of supplementation for patients, like in doing this holistically, I do detox, support your adrenals. I start them on Mighty Maca, support your adrenals. For me, it's my keto-green method, intermittent fasting, because we want to manage insulin, increase our insulin sensitivity. And then it's progesterone and pregnenolone, and then DHEA, and then testosterone and estrogen. Usually in that order, sometimes estrogen, then testosterone. Depends on, really depends on what you need.
What about the doctors that just medicate? They just say it's menopause or it's perimenopause. This is normal. Here is an antidepressant and birth control pills.
Right. And that is still widely used today. And this is a disservice to the human body. It really is just a disservice to the human body. And as I mentioned, every hormone has a sister neurotransmitter. And so is it, is anxiety, depression, is it bipolar, or is it your hormones? And usually you fix your hormones, support your detox pathways, get some good night's sleep, add the right micronutrients and nutrients and supplements. And I honestly haven't written a antidepressant in years for patients because they feel better. And you, again, part of my platform, though, of course, Natalie, you know this, it's always to do things to increase your oxytocin level and to manage stress. So we increase oxytocin and it makes all the difference in your body. And we make it within our body. So being able to incorporate these things makes a big difference. I'll share with you on this because we talk about nervous system and these issues. I had a client in my office several months ago. I had her follow up yesterday, but when she's 51 years old and menopausal, when she first came to my office, she could barely sit in the chair. She was anxious. She was jittery. She was nervous. I'm like, okay, what are you taking? How much caffeine have you had? She's like, nothing. She's not like, she was totally anxious and like really friable, right? And okay, we got to work on vagal tone, get you into your body. She's like, well, I want to adjust my hormones. I'm like, we will get there. We'll definitely cover your hormones, but this is not your hormones. Like this goes beyond your hormones. And then as follow up, I really talked with her about oxytocin. And for her, I did prescribe some oxytocin nasal spray exogenously just to use to get that feeling. She's feeling like she's going over the edge. Let's just add this here. Keep working on detox pathway, hormones, nutrition. And I saw her yesterday. And she was just like, she's like sitting, relaxed, telling me about the boundaries she's drawn with her husband, stood up for herself and, is enjoying her life and, and it's just really tapping into her spirituality and friendships and like all the oxytocin increasing activities. And that, just to see her that way, because like, at first I saw her, I'm like, I may have to admit her, right? That's how I felt.
So I want to talk about that nervous system a little bit more, because I think especially the women that are very vocal right now about perimenopause, menopause, postmenopause, a lot of us we're Generation X, right? Gen Z. No, Gen X. What am I? I have my letters backwards. We're Gen X. We're Gen X. So we grew up with kind of tough it out and, don't talk about your pain or your symptoms or all these things. And I think a lot of us have higher cortisol, poor nervous system regulation because of that. Plus, in our years of perimenopause, many of us, we started getting hit with social media and cell phones and blue light, all this stuff at one time, right? It starts coming at us. So we already had this different way of managing our cortisol and stress and toughen up. I mean, therapy was like not our generation. That was next, right? We would just tough it up. So now we've got these compiled nervous systems, and then we add the blue light that we didn't have before, and cell phones and social and all this stuff. And our nervous systems are a freaking mess. And I think that's also contributing to a lot of problems.
Absolutely. And I would just add, in the 80s, we had the low fat, no fat movement.
Oh gosh, that's right.
That no fat, hormones are derived from fat. Like we have to pay attention to that. I mean, like that's so important to have good, healthy, balanced fat, avoid seed oils and, the bad fats, all that good stuff. But, we need healthy fats. But we had a generation. I mean, I was in that low fat movement and I kept, of course, gained a lot of weight.
Oh yeah. I used to get like a big bag of gummy bears fat-free, but they're fat-free. Remember that?
Popcorn.
No everything butter. That's fat-free, it's okay.
Right. And it's just, so we really, I think that did a lot of damage to our hormones. That increased, I mean, you think about fibroids and endometriosis and PMS and those symptoms. But, we derive our hormones from cholesterol. So, yeah.
So Dr. Anna and I, we've done this before. We're doing it again. We're doing it one night on 9/18. So Thursday, 9/18, mark your calendar. We are going to do a class where we're going to deep dive more around this. So if this is resonating and you're like, but you didn't answer my question, or I've got more concerns here, and what about how I'm wired and what I should be doing, and what are the things that I need to be doing to be setting myself up to win with hormone replacement? Like if you're going to do that, or what if I choose not to do HRT? What else do I need to know? We are going to do a free class. Now she does a series of these, but I want you to come on the one with me because we're going to continue on this conversation here. So if you go to midlifeconversations.com/magic. So midlifeconversations.com/magic. There'll be a page you can register. It is free, but you do have to save your spot and then show up so we can help you. I will kick it off. I will introduce Dr. Anna. She is going to teach and lead, and then we stay on as late as we need to answer all of your questions. So we don't leave anybody with unanswered questions. So it is a great time to come on and get your answers around this and get support here. So I will put all of this in the show notes. If you're watching this on YouTube, it's in the link below. If you're listening to it on podcast app, it's on the show notes. You can hit on that exact link. You can also go to my social media, and depending on when you're listening to this, I'll probably have a link under a video with Dr. Anna and myself. So you can find that there. But midlifeconversations.com/magic. And then can't wait to see you on there. Anna, why should they come to class? I don't even know what you're going to be adding in special this class. Is there something like you have to come because of this, or what do you want them to know?
I definitely think this conversation about our mental health, brain health, I really see that is a bigger need now than ever. Yes. So the effects of stress, the effects of hormone disruptors, but how we empower our physiology, because it takes more than hormones to fix our hormones. Certainly it can dive deep into hormones at any time, and that's part of the conversation. But it's really, how do we empower our body so that we are living our best life? So what do we need to do to really fix our hormones? So I'm going to hit on some really key areas, and especially how it relates to how we show up in the world. How are we making decisions? How are we thinking? Are we happy? Are we having fun? I'm sure to include that.
Thanks for watching another episode of the Girlfriend Doctor podcast. Check out all the links below for more.